Another session of Southwest London Education Forum for Pharmacists. So today's main clinical topic will be mental health. We have Caroline Morrison coming from St. George's. She will be doing the second half of the session today because she has clinics and we were worried that she might run late. Unfortunately, Chadney is not with us today, so I'll be mainly focusing on the first part of today, which is the clinical supervision. And I thought to keep it in line with today's topic, so it's going to be about mental health case discussions. And I would really ask you all to be interactive, because that's the whole point of being part of the clinical supervision. There's no point just me putting those cases and saying my point of view. It is a learning session, a supporting session, and it only works when we discuss and we learn from each other. So I might say something and then you have a completely different view. So I need you to be active with me. Unmute yourself, put your hands up, put it in the chat, whichever way you feel comfortable with. And we'll just go with the flow. So I'm just going to share my screen now. Let me just take them.
Is there any way to make that bigger?
The slide.
Yes.
Is it? I have not shared it yet. So.
Oh, okay.
Is it showing?
No, Hala, it's not.
No. Okay. So can everybody see my slides?
Mm-hmm.
Great.
Are you able to make it into presentation mode, Hala?
Oh, is it not? Okay, I think
no.
I have. Is it now?
No, not yet.
No. Okay, let's just get exit that one. How about now?
No. Did you click on the individual slide icon?
It's not showing what. Okay, let me just try to change the screens then. Any change now?
No.
I think because I have two screens open, that's why. Any luck? No?
No. Do you want me to share, Hala, if you send it?
Okay, I'll send it to you now. 1 second. Okay, so that has been sent. Let me just stop sharing my screen. Okay, so I'll wait for Nisha to share the screen, but I think mental health is one of those topics that we come across quite regularly as pharmacists as part of our medication review, whether they are taking medication and then they express their concerns regarding their mental health, or you start a medication review and they are already on a medication and then you're faced with changes or recommendation. Now, the 3 cases I have, 2 of them were from this week and 1 of them was from a few weeks ago. We'll go straight to the first case. So he's a 52-year-old male booked for a med review with Pharmacist. His main concern was just to have a med review. He has chronic back pain and his current pain was 8 out of 10. He has increased shortness of breath and no ankle edema. So next slide, Nisha. So if you look at his active problems, he has ischemic heart disease from 2000. He has heart failure and he has depression that is from about 2.5 years ago, 3 years ago. And this is his main kind of like what he was booked in for a review. Next slide, Nisha. So looking at his observation, his blood pressure is nicely controlled, 115/80. That was from August. His weight was 112. A BMI is 40.2 almost. There's no update on his smoking status, and there is 0 alcohol intake. Again, it's quite old. Next slide, Nisha, please. So this is his current medication list. So he's on amitriptyline, to be taken at night for his pain. He's on GTN, which he's not using that often. Mirtazapine, 15 milligram at night. Warfarin, because he had 2 heart attacks within, I think, the period of 4 to 8 weeks. He's also on aspirin, atorvastatin, bisoprolol, and the Zinipro. So this is his current list of medication. This is what we typically get on our list as pharmacists, to have a med review, heart failure review. And then the more you talk about things, the more you discover, okay, there is another layer that I need to uncover and discuss further. Now, as I said, this is a very interactive session, because if we want it to be a clinical supervision, I will need you to be on board to understand your opinion, to learn from each other, to see what you think. Next slide, Nisha. So within the medication review, if this is your patient and he came in for a review with you, what would you be prioritizing? What will you be monitoring? What advice will you give, and what recommendation would you put for the patient to the doctor? What things would you suggest to change for this patient? So I'm handing this back to you guys. I'm happy for you to raise your hands, put it in the chat, unmute yourself, whichever. But I need some replies. So as we said, he's 52-year-old. He has back pain. He's heart failure, shortness of breath. Quite a few symptoms. He's on mirtazapine. Why is he on aspirin and warfarin? Indication for both. So I think because of the high incidence of clotting, he is under cardiology. He is on the INR. They tried him with a apixaban, but he didn't get along with it. So they advised for him to continue with both. There's no bleeding. So yeah, and the cardiology definitely wanted him to be on both.
I would want to find out what his mood is like, especially given his pain history.
Yes, so I think his main focus was the pain, which is kind of like affecting his mood. He has been reviewed, I think, in 2 years ago, and he was advised to have mirtazapine. The mood is okay, but he's fed up with the pain.
Hmm.
Okay, so somebody else, if I can flick through meds and bloods. Okay, so Nisha, can you go back a couple of slides, please? So
Just one thing out.
Yep.
Just one thing I wanted to say with regard to the mirtazapine. Based on his BMI, that might not be the best choice for him once the pain management is optimized.
Okay, so we're looking at mirtazapine as not the best choice. Why is that?
Because it can cause weight gain. So right now the priority is managing the pain so that he gets in a better state. But once that's optimized, then one might want to look at explore what his thoughts are regarding the antidepressant. If if the weight gain that can happen is a concern for him, if he's interested in losing weight, or if because for some people their weight might be contributing to their mood as well. So I know that for him the main issue is pain, but just explore his thoughts regarding that.
Sure. So we need more. Sorry, Nisha, can you move to the next slide, please, which has the medication? I think quite a few of you wanted to see it. Yes, absolutely. I think exploring his pain relief medication, exploring also his mood, and then focusing on the patient's concerns and your concerns at the same time. If you can match both things at the same time, so it's a win-win situation. So if you have something that you think can help with the pain, also help with the mood, then I think that would be a great solution, especially if you can discuss it with your supervising doctor, the on-call doctor, whoever you're going to approach. With his shortness of breath, does he have any pain in his chest? Is he on any diuretics? He's not on a diuretics. He has no chest pain, has not used his GTN spray in a long time. Now, duloxetine, yes, Lillian, I agree. Duloxetine might be a great option where we hit two birds with one stone, where you really try to control the pain and at the same time has the antidepressant effect, and it doesn't have any negative impact on the weight. He's not a diuretic, as I said. There's no ankle edema. There is he's stable from a heart failure perspective. So is it the weight that is causing this shortness of breath? So again, exploring more on that to see when does that shortness of breath come in? Is it during exertion? Is it at rest? How many pillows does he use? So we just need to get more information about the shortness of breath. The chronic pain, he is under the pain team. He sleeps well at night. He takes 2 amitriptyline. So that tells me that the amitriptyline, if somebody normally sleeps well at night with the medication, so most probably they're not waking up because of the pain. So there's good control. So it's the daytime control that we need to look at. Any other things that you guys would discuss with this patient? No, okay. So the rest of his medication, they're out of sync. So one of the things that I do all the time is I try to synchronize medication together. It reduces workload. It is a better impact for the patient, especially if he's struggling to walk around and having to go to the pharmacy on regular trips. They really appreciate it when you put an effort and synchronize the prescription. So increased risk of bleeding. I think with all SSRIs, there's increased risk of bleeding, but because he is already, and the type of bleeding that we get from warfarin is subcranial, while is with the SSRIs is a GI bleed. So definitely, if we're gonna start him on a duloxetine under the supervision of a doctor, I'm not a mental health prescriber. So I will discuss it with my GP and I'll see if we start the duloxetine, his INR will need to be repeated, make sure that it is within range, advise patients about risk of bleeding, and with the aspirin, he might need a GI protection like a PPI. And we can see which one we're going. So citalopram has also a high cardiovascular interaction, especially with the amitriptyline. They can prolong the QT interval. Yep, Lynette, gastric protection would be a good idea. Anything else, guys? Anything you think we can do for this patient? So I always encourage my trainees. So I do pre-reg pharmacists, and I always try to encourage them to look at non-pharmacological options. We shouldn't just focus on pharmacological options, but explore the other options that we can offer to the patient. Physio, 100%. Social prescriber. So I think utilizing the social prescriber within the PCN is a really valuable thing. Weight loss, yes. So he is a high-risk patient. We can refer him to the tertiary management or tertiary specialty for weight management. He's eligible because he's high risk. Any other services that you guys can think of that you can refer the patient to? Health and well-being coach, yeah.
Hello. He doesn't seem to have had things like HbA1c and that kind of thing, or like a BNP for the heart failure. Like he's got the GTN, which implies that he's got some issues with cardiovascular disease.
So he did have a heart attack twice, I think, in 2017. Let me just try to remember the patient. 1 second, because he's on my EMIS, so I should be able to bring it. 1 second. I can give you more information now. Just bear with me.
I mean, is his main concern the pain? Is that why he's there?
Yes. So he was booked for a med review because it's red on the screen, and he was due for a med review. But as he was discussing this with the pharmacist, he was discussing about the pain, but the pain has been ongoing for many years. So it's nothing new. It's a chronic.
Okay.
So I think having that discussion about chronic pain and the expectations of the management of a chronic pain, what is acceptable level of pain, how much reduction can we reduce it? All of these things need to be addressed with the patient. There is no HbA1c done for the patient. The last thing I have is a serum lipid. The triglyceride is 2.5, but the cholesterol over HDL is 4.8. So within range. It was higher before, but now it has come down a little bit. Triglyceride, historically, he has it high, 3.6, 3.3, 4.0, and now reduced to 2.5. So definitely, I think testing HbA1c would be a good idea, just to check if there is any raised HbA1c. Looking at his history, he's 52, so quite young when he had his heart attack. If we look at his heart attack, it was in year 2000. So probably he was in his 20s. So quite a lot to go through when you're quite young. So definitely exploring, maybe referring to the lipid team. Maybe he has hypercholesteremia, familial hypercholesteremia. Again, he's on the maximum dose of atorvastatin, but his triglyceride is still going up. So definitely, I think referral for weight management team, discussing alternative for mirtazapine, looking at HbA1c, referring to a lipid management team at the hospital for further input. So quite a lot can be done for this patient. And as I said, he is quite young, and sometimes a simple med review can trigger quite a lot of investigations. Anything else for this patient? What is adherence to? He's fine. He's taking it regularly because it helps with his sleep. So he's been taking it quite regularly.
I suppose on the same kind of idea as your sinking meds, there's things like the mirtazapine is 28 tablets, and maybe putting more things on the RD if they're stable and ongoing.
Absolutely. So we can move the amitriptyline to his repeat dispensing. The mirtazapine, if we are going to change, then I would keep on the repeat until I make a decision. And then once we reach into a conclusion of which medication we want, then we can move, and he's stable, we'll move it to the repeat dispensing. Anything else? Is he experiencing any side effects, any recent changes to health? No, he's stable. He did not mention any side effects at all. So I think with the cardiovascular repeat dispensing medication, he's been on it for 20 plus years. The same with warfarin, he's been on it for at least, I'd say, 10 years. The mirtazapine has been on his list for, I need to look into that one. So he's been on mirtazapine since 2021. So again, he's been on it for quite some time. And if I also add his, yeah, so he historically was on the higher side. So in 2013, he was 91 kg and then up to 112. So about 10 kilos increase in about 11 years. Yeah, so definitely, I think weight management, lipid management, review his antidepressant to something that is more effective, maybe, as we said, duloxetine for both. Further investigations for HbA1c, BNP. Hello, am I still on, or did I get kicked out?
Hala, are you there? I think she did get kicked out. Let me just message her. You're back now, Hala. You're on mute.
Sorry, got disconnected. So that's our first case. Anything else, guys, that you want to address for this patient? Okay, so we can move on to the next patient, please. So this is a 57-year-old female booked for an asthma review, increased shortness of breath, and shortness of breath is affecting her quality of life, not life, sorry. I did not check my spellings. Next one, please. So this patient was booked with the asthma nurse as an increase of her symptoms. If you can see that she has dependent personality disorder, emotionally unstable personality disorder, essential hypertension, COPD, discoid eczema, and asthma. These are her main active problems. Okay, so she does have asthma and COPD plus hypertension. Next slide, please, Nisha. Now, her observation, again, a very high BMI at 45. Her body weight is 106, height is 153, blood pressure on the high side, 137/102. She's currently smokes 10 a day, I think 28 years pack. 0 alcohol intake. Next slide, please, Nisha. Her medication. So she's on acyclovir, amoxicillin, issued in April. Quinine sulfate on an acute prescription. She is on salbutamol nebulizers. Gaviscon, prednisone, she used again as a rescue pack early April. Symbicort high strength. Tramadol, cocodamol, diazepam, esomeprazole, furosemide, metoclopramide, mirtazapine, nitrazepam, ramipril, rosuvastatin, multivitamin, vitamin B compound, and the salbutamol inhaler. So quite a long, lengthy list of medication. Next slide, please, Nisha. So again, we're going to look at the management of this patient, the prioritizing, the monitoring, the advice and the recommendation. So which page do you guys want to go first? To the observation or to the drugs? Okay, can we have the drugs, Nisha? So the previous slide, please. So from the OBS, James, it's mainly high BMI, blood pressure is slightly also raised as well. But otherwise, I'm still a smoker. So that is mainly for this patient. Now, what would you look at? What is your first thing to assess for this patient? She is overusing her salbutamol inhaler twice a day. She's using the nebulizer at night. She is compliant with her Foster. She's using it twice a day. She's taking her other regular medication with good compliance. What else would you address with this patient? What would you look at? We said her main concern is increased shortness of breath. Smoking cessation and weight management. Yep. So smoking cessation, I think this is being addressed every single time. Inhaler technique, yep, definitely. So she's been on them for many years, but definitely check the inhaler technique. Is that trigger causing this shortness of breath? It's worsening symptoms of her shortness of breath. COPD review, introduce LAMA, consider a triple inhaler. Absolutely, I think that is something that we can look at. Tramadol, cocodamol are respiratory depression. Yeah, absolutely. Chest X-ray. Yep. So when you're thinking about all of those things, when I discuss with my trainee pharmacists, I always tell them, don't look just at the condition, but look at the patient. At the end of the day, what we need to do is individualize or care for the patient. So we need to look at this patient. If they step into your clinic and you're looking at them and their shortness of breath, what would come to your mind? Now, when I look at the amoxicillin, they have been requesting amoxicillin every single month for 12 months. So are they using it because they have shortness of breath? Why are they being prescribed? ACV burden, okay, not sure if you can, no, I can't, Risikat, are you unmuting yourself? Okay, no, There's no sound coming. More than happy for you to type for us. Sputum sample, okay. Yeah, is the patient assuming that their symptoms is because of asthma or is it because of COPD?
I mean, I think there's a lot of possibilities that can cause shortness of breath, and it's quite easy to jump to the asthma as being the cause. But I think maybe asking, like taking a history and looking for wider things like ankle swelling, like she's on the frusemide, on the repeat dispensing. So is that because she's retaining fluid or something like that? Could it be heart failure? Could it be AF? Like, when does it happen? So I think a wider history would be worthwhile to see if there could be other causes of the shortness of breath. On a second point, I was a bit concerned.
I agree, because nothing has been documented for her heart failure or cardiovascular disease.
Yeah, I was concerned a bit about the nebulizer because they're not recommended really unless it's under respiratory. So, like, did she buy it in Aldi, and why are we facilitating it if that is the case?
Absolutely, I agree. So again, the nebulizers, why is she using it before she goes to bed?
Yeah, and does it even work? Do you know what I mean? Yeah, also the Vitbico strong, like, why is she on those? Because I think in the OBS she's not drinking. So usually people are on that because they have an alcohol history.
Yep.
So that's a question. Maybe
Yep,
she had a gastric band. I don't know.
Yep. So she was recorded as 0. But if she's on both, historically, has she been on increased alcohol intake, and this triggered this prescribing and was never reviewed?
Yeah. Also the multivits, we normally say you have to buy those. So
yeah.
Unless they're bariatric or something.
Well, looking at her weight, then I think it is definitely not bariatric, because she has been refused because of her shortness of breath, I think. So
okay. Yeah.
As a management wise, and when I was approached about this patient and they told me, okay, we think her asthma is worse, shall we refer to respiratory team? I think having an honest and open discussion. Oh, another thing I forgot to mention, that the patient is troubled by her large breast, and she wanted a breast reduction surgery. What's she long-term topical not recommended? Well, yes, I agree. It's not recommended. It can cause cardiovascular problems, but she is on quite a lot of different opiates, so maybe they're causing nausea. She is on different medication that can cause respiratory suppression, as mentioned in the chat. A long list of medication that have probably compiled over the years by adding one at a time. So I think having a really focused discussion with this patient about her list of medication, about deprescribing. Mirtazapine, again, is a 45 milligram, and we know, as we discussed with the previous patient, that they can increase appetite, and that can have its own input into the weight gain, and she's already with high BMI. So having a discussion about changing mirtazapine to something else that can help with her symptoms, reduce, is it anxiety, is it depression, which one do we think is better going to be for her? Educating about amoxicillin, why she's using it every month. Is there a phlegm? Does it have a color? What are her symptoms? What is triggering her request for the amoxicillin? Is she having sleep apnea because of her weight and COPD? Does she need to be referred to a sleeping clinic? Assessing a chest X-ray, definitely, to see if there's any changes. BNP, again, she is on furosemide. I don't know how long has she been on it. What is the indication for that one? Prednisolone on repeat. How frequently is she using it? She's not using the prednisolone that often. So I think she had 2 courses over the past year. It's the amoxicillin that she's requesting regularly. So I'm assuming the prednisolone, she didn't feel much of a difference with it. Anything else that you guys can think of for this patient? She's on a high dose of esomeprazole, 40 milligram twice a day. She didn't have, I think, sorry, Nisha, can you go back to the 2 slides back? One more. Yep. So large hiatus hernia. So yeah, I guess she needs to be on a high dose of PPI. COPD taken 5 days. Yep. The problem, Kahai, is the patient is more being dealt with more of an asthma than a COPD, and this is the issue. I don't know why it's overlooked as overlapping of both, because she's an active smoker, so should be looked at. Can we move back to the medication list?
I mean, it might be worth looking at her eosinophils to see what degree of inflammatory asthma.
Yeah, no, I think eosinophils was fine on her last test. Just bear with me. Yeah, eosinophils is okay. It was high once upon a time in 2004, which is probably when her asthma was more active. But for the past, I would say 5 years, it has been within good range.
And she's also on those 2 benzo drugs, the diazepam and the nitrazepam, is that right?
Yes, she is on both. So again, we have high diazepam dose going in, so 10 at night of the 5 milligram nitrazepam. She's taking 40 milligram of diazepam per day. So now there is no point of being shady about approaching drugs and the effect of drugs. And I think being very clear and very open that everything that you take will have a side effect. And even though that you did not experience that effect when you're younger, you have changed, your body has changed, and the side effects will probably be more prominent as you grow older. And having that discussion with the patient, because if the shortness of breath is reducing her quality of life, then she should be open to discuss her current medication. There's no point of keeping everything as it is and just add on more things. We need to discuss, okay, we might want to explore stopping some of your the diazepams and reduce your tramadol. Most probably your pain is related to the weight. Let's refer you to the weight management team. Again, she is eligible because she's high risk. So refer her to the weight management team. Her blood pressure is high, so it's not well controlled. She's around 5 milligram and no other medication. Do we need to up-titrate the ramipril, add amlodipine? Do we need to do an echo just to check the heart if there is anything else going on that side? Check her MRC score. How far can she go without getting out of breath or stopping for rest? Again, so it's a COPD review. And so it's quite a lot of things to touch on. So it's not just a direct medication review that will happen in 10 minutes or 15 minutes, or even 20 minutes. This is one of those that you will really spend quite a lot of time, and you need different teams to be on board with you. Any other inputs for this patient?
I think also it might be quite useful to go back through her correspondence and understand like how she got here. I mean, some of it might be valid because she's got that personality disorder. She might be under psychiatry or something, and they've tweaked it to this point, and this works.
I agree, but I think again, now even as a personality disorder, I think making sure that the patient understand once you're diagnosed with one thing, it does not stay stable throughout your lifetime. So they need to reassess and refer and tweak again. So there's nothing called steady state.
No,
just
I
like
agree.
with asthma, Yeah, so even with asthma, when I say my patients, I tell them just as we step up in your treatment, we step down, and sometimes we'll even stop your medication. I think it's empowering for the patients knowing that things can change in a positive way.
Yeah.
So addressing the weight, addressing her concerns about her breast slide, especially after the menopause, she felt they are much bigger, they're affecting her. So does she feel like the extra weight is affecting her breathing at night, and that's why she's using salbutamol? So again, she needs a lengthy appointment to discuss all of these aspects. Combination of benzodiazepines. How sleep is day to day. I think you get used to it. So we know with the opiates and the benzodiazepines, there's a tolerance after a while. And she's looking at the nitrazepam. This is a medication from probably the early 2000s, and most probably she's been on it for what, almost 20 years. So tolerance most probably is there, but it becomes a psychological attachment to it. So quite a lot of things to address. So this is a typical case of polypharmacy. Quite a lot of different conditions that are interlinked. We can use different teams to support us with the prescribing and improving her quality of life and the outcome. So refer to respiratory team, but after investigation, cardiac probably if we think there's a possibility of heart involvement, de-prescribing of addictive drugs, getting health team on board, weight management, as we said. So yeah. Okay, shall we move to the third case, please? Thank you. So this is one of my complex patients. So a 42-year-old female booked for HRT review with myself, works in a high-performing job, has 3 children. The youngest is 4 years old. She's highly educated. She really spends time to investigate each drug that she needs to go on. Her mood is stable, but can get agitated due to work and family commitments. She suffers from brain fog and low focus, and she can get irritable quite easily. Okay, so these are her main symptoms for this lady. Okay, I've been in contact with her over about, I'd say, 3 years. Next slide, please, Nisha. So these are her main problems. Hypermobility, vaginal pessary is not a problem. She had ECG, and then she was diagnosed with postural orthostatic tachycardia syndrome. She had depressive episodes over the years, but I think the first one was recorded in 1997. She has contacted us over the years for low mood. Next slide, please. So her observation, her blood pressure is on the lower side. She doesn't consume much of alcohol. Her BMI is within range, although this is an old reading, but she's an active lady. Next slide, please, Nisha. So list of medication. Midodrone was prescribed 1 a day, but can increase to 2 a day. She's under cardiologist. She's not keen on it. She tried it, caused side effect, and stopped. So the cardiologist prescribed the medication and left it to the patient to kind of like monitor what is the most effective dose for her. Other medication is amitriptyline, 1 or 2 at night. She's taking it to help with sleep. Citalopram, 1 a day. She is on the pessary. Dry eyes, omeprazole to be used for gastric reflux, nasal spray, and then she is also on the Estradot patch 100 microgram. She has a Marina Cord Institute as well. So, any thoughts about this patient? What is her main concern, you might ask? Okay, so what is the dose of Estradot? It's 100 microgram, so the maximum dose. Now, her main concern is, again, when she called for an HRT review, she said she had breast tenderness, but her symptoms were much improved. She's very adherent to HRT. She is taking it regularly. It made a difference to her. Refer to have her estrogen review and possibly increased. Okay. Does she have estrogen opposition? Yes, she has the Mirena coil. Does irritability due to depressive symptoms? Yes, very much so. Could be because she has history of depressive. Is she examining breast regularly? Yes, she is. Could you check estrogen level? Okay, yes. So it is not common practice to check estrogen level. Okay, Kahai and Risikat, can you either unmute yourself and tell me why you want to check the estrogen levels? You need up-to-date weight and blood pressure, ideally, 100%. Yes, Natalie.
Hi, it could be that the estrogen's not being absorbed.
Pardon?
Even though she's on a high level, blood tests just dictate whether it's being absorbed.
Okay, so we can look at the estrogen levels being absorbed. So we know transdermal absorption is much better than the oral because it skips the first part. Oh, sorry, I can't hear you. Okay, so Nisha, can you go back to the first slide of case 3, please? So let's look again at the age of her children. So she's 42 years old and she has 3 children. The youngest is 4 years old. Now, when I went back home, so I spoke to this patient, and for me, her symptoms of breast tenderness means that there is an overdose of estrogen. So I need to reduce the dose back. And then I went back home and I'm thinking, she's 42, her youngest is 4 years old. Could it even be possible that she is perimenopausal or postmenopausal? What do you guys think? What does NICE guidelines say regarding the age? So this is where we look at each patient individually, and this is a personalized care of each patient. Well, she has a Mirena coil, unfortunately, so I can't tell when was her last period. Did her cycle restart after 3rd child? Yes. So again, investigating further. So looking back into the consultations of this patient, as I said, she's in a high-performing job. She's stressed, and then there is this whole new talk about HRT and how can improve symptoms and what symptoms are of the menopause. And then she started to link things together. And because she's highly educated and she reads a lot, she can sound very convincing and she can push for what she wants. So when she had her review with one of the GPs and explained she's having irritability, she's not sleeping well at night, sometimes can have hot flushes, we really should have checked her levels of the luteinizing hormone and FSH, okay? Because we need to establish, is this woman having low levels? Because technically speaking, and looking at her age and the age of her youngest child, she shouldn't be perimenopausal. So we should have investigated things more. Now, when I came to review this patient and I told her, okay, you're on a high dose of estrogen, let's reduce it a little bit. She said, but it's working for me. It's like, okay, it is working for you, I can understand, but we need to understand if I'm giving her 100 microgram and she's not really perimenopausal, she already has her estrogen, I am increasing that risk of breast cancer more than the usual. I am putting her at risk. So I tried to explain to her, okay, let's reduce it a little bit. She wasn't keen on reducing that estrogen to 75, but we agreed to it. She's on citalopram 10, so increase it to 20. She completely resisted stopping the HRT and do blood test. So I agreed to refer her to the menopause clinic for further investigation. So this is where I say sometimes you are looking at one thing, but then you think, does it really make sense? Yes, it was started by a GP, but do we think that this patient is going through a depressive episode? And then she thought it is more related to HRT, because even now she was reviewed by cardiology, and she thinks that since starting the HRT, it has improved her postural, I think it's called arrhythmia. What was it called? POT. I think that the abbreviation is POT. Postural orthostatic tachycardia syndrome. So in my opinion, I think anxiety is a massive, massive issue with this patient. And even when we started with her this citalopram once upon a time, like about 3 years ago, certainly post libido, she didn't want it. Citalopram had increased QTc interval, and she's already on amitriptyline, so she was worried about that because of her cardiac history. She wasn't keen on mirtazapine because it increases weight gain. So this is one of those patients that you really need to kind of like look at them, and rather than give them what they think is correct for them, is to assess from a medical perspective what is safe and effective. So I thought this was a really, really interesting case, at least it was for me. Any other things that for this patient you would probably think about or address? Okay, Nisha, if we can just run the first Menti, and then hopefully is Caroline in now?
Yes, hi.
Hi, Caroline. Sorry I kept you waiting. So just a quick Menti, guys, just to see, because of this session, it was different clinical supervision. So your input will be well appreciated.
Okay, guys, please. Sorry, Hala, go on.
So yes, either use the code or scan the QR code, which will take you to the Menti. Yes, Pfizer, I think patient support system definitely need to be looked at to see if she's having a balance between work and home. Okay, shall we give them 30 seconds, Nisha, if you put the timer, please.
As Chani would say, I have not received a lot of love, only one person.
Send us some love, guys. Thank you. It's coming through now, Nisha.
Yeah.
Thank you, guys. I can hear chatting in the background, so sending you much love. Okay, so which bar do you work in? If you guys just give us a quick answer for that one. Okay.
Cool.
Okay. Now, this was because this is a trial of the clinical supervision. I just wanted to know your opinion on today's session. So please choose one of the options. You want to give it 30 seconds, Nisha, please? Thank you for the thumbs up, guys. And the last question for this session.
Oops. Okay. Yeah.
How useful were the case studies? They were quite variable in the nature, but I think this is what we face day in and day out. Do you want it to be more specific? Do you think that it was too much? Do you want to give it another 30 seconds, Nisha?
Mhm.
Yes. Okay. So thank you guys for your response. We'll have Caroline now, who will be doing her side of the mental health review. Welcome back, Caroline. Always pleasure having you.
Hi, Hala. I don't know why I'm not appearing. I've just got background. My camera's on.
I'm loving the background though.
But like you can't. I don't know. I'm suddenly turned into a ghost. This is bizarre.
Yeah. Oh.
I'm really sorry. I have no idea what is going on. Camera's on. My cover's open.
Okay.
Yeah, I can't explain it. And I mean, you're not missing much, but it's always nice to see people. And I don't.
Absolutely.
Yeah, I'm
So,
sorry.
Caroline, no, it's okay. Do we have slides for the presentation?
So I did put together some quick slides this morning.
Thank you.
I don't like to be too
Thank
prescriptive in my slides because I like, especially when you talk to a specialist, I like it to be a bit more nuanced. And you can go to you can go to NICE guidelines or the depression guidelines and you can read all the the kind of black and white stuff, but I prefer this to be more about the gray. Psychiatry is very gray. It is very nuanced, and I think that kind of serves people better than basically regurgitating what's out there already.
Yeah.
Okay, do you want me to just send it to you? Will I? Do you want me
Are
to?
you able to share your screen, or do you want to send it to Nisha?
Let me just send it to Nisha, only because I'm completely illiterate when it comes to anything, and that sounds ridiculous, like IT. I will at some point mess it up.
That's me, Caroline. Don't worry. I managed to log out. I managed not
and
to. Yeah, don't worry. You're not the only one.
I'm sure Nisha's much better than me. And it just gives me one other thing not to think about. Okay, just says in draft, I have to say. So I just put this together really to help me kind of give myself some sort of structure in terms of what I am talking about. Because any of you that know me will know that I like to talk.
Honestly, your talks are amazing, Caroline. Every time that you come and give us a talk, there's so much that I take away.
Oh, you're very kind. My dad always says, I didn't kiss the Blarney Stone, I took a bite out of it. So please stop me if I start going off on a tangent and just talking about something that I get passionate about. Yeah, please do.
No worries. I'm sure you're gonna give us a lot of your wisdom today.
So we've got pharmacists and technicians, is that correct?
I think mainly pharmacists.
Okay.
I think so, yes.
Okay, great. So we're going to talk about anxiety and depression, mostly depression, to be honest. Oh, sorry, somebody just come into my room. They can't see it, don't worry.
Do you have the slides, Nisha?
Not yet, Hala.
Okay.
Okay, just got them now.
Thank you.
I'm really sorry. Sorry, one of my patients turned up early. But she's not due yet, so it's all fine. I've sorted it. I do apologize.
No worries.
Okay, so take two. I'm gonna talk about depression and anxiety, mostly depression really, because I think anxiety, there's so many different anxiety disorders, and they're so specific. That would be a talk all on its own. So anxiety it's kind of incorporated in terms of the medication we use. We usually use the antidepressants, and certainly in primary care, that's what you'll see used for mostly generalized anxiety disorder. Also, obviously, you've got them panic attack, you've got PTSD, you've got OCD. You know, there's a whole social anxiety. There's a whole host of anxiety disorders under the umbrella of anxiety. So I won't touch hugely on anxiety specifically, but it will come under the kind of treatment umbrella for depression anyway. And when it comes to deprescribing as well, it's usually the same meds. Okay, so just to give you a bit of background, I think it's always interesting, and usually when I do talks, especially when I go and I speak to the pharmacy students about schizophrenia, they generally find it interesting to go back to where we started and what we used to do for patients back in the day, so going back to the kind of start of last century, we used to just send people to asylums. With the big asylum movement in the late 19th century, and people were just sent away to the peaceful country. You'll see, so I've seen loads of old documents from the old asylums, and they use terms like she was blighted by melancholy. That's how we describe depression, back in the day. And then obviously post World War II, they actually had a whole glut of hydrazine, which was used in some of the bomb making, I believe, and they decided to use it to experiment on. And so we had the introduction of some of the antipsychotics, which they then discovered had antidepressant properties, and so from some of the antihistamines as well. And so we had the advent of your tricyclic antidepressants, obviously initially, is what we used. Obviously not ideal in terms of their cardio toxicity. And so then we had the big move of SSRIs. And really, we haven't really had any kind of big moment in terms of treating antidepressants since then. Since SSRIs, there hasn't really been anything that's kind of revolutionized. We've obviously got all the psychedelics coming through and showing there's great success, but obviously with that comes a lot of red tape, etc. So it won't be anytime soon that people will be treated with psychedelics, and we can talk about that all day as well. So epidemiology, so just talk about how many people get depression. So in terms of Europe wide, the prevalence is about 2 to 7% in terms of lifetime prevalence in Europe. If you compare that to schizophrenia, it's about 1%. ADHD in school-age children is 3 to 5%. So I mean, 7%, that is a lot of the population that will suffer from depression specifically. And there are differences in terms of genders. So women are twice as likely to suffer from a depressive episode from menarche to menopause. So I'm sure all the women on the call today will absolutely recognize that hormones have, a place in influencing people's mood and emotions. So unfortunately, us poor women are twice as likely to suffer from depression during those fertile years, if you like. And there is about 40% of your chance of depression is based on genetics, and then the other 60% is environmental. you know, and we could talk about that again, socioeconomic, depending on your background and where you're brought up, etc., etc. All those factors will play a part in whether you will develop depression. And we talk a lot now in psychiatry about vulnerability. So rather than necessarily saying, you know, they've got what their risk is, we talk about having a vulnerability to, because you may have a genetic risk, but in terms of your vulnerability, there will be so many other factors that will play a part in whether somebody goes on to develop depression, anxiety in the future. Okay, so diagnosis. Sorry if you just go back, Nisha. Thank you. Oh, back.
Sorry, Caroline. Let me just.
You're okay.
Sorry, let me just reshare.
Anyway, I'll keep going. So diagnosis. I mean, I'm not going to list the symptoms of depression for everybody. I'm sure everybody's well aware. But in terms of kind of those core symptoms, we're obviously looking at somebody that with a reduced mood for most days. And in terms of treatment and in terms of, you know, how severe the depression is, we obviously look at whether or not it impairs their ability to carry out, you know, activities of daily living, and whether or not they have suicidal ideation. So can the person still function? You know, do they still go to work? Do they still get their kids up? Do they still do everything that they usually do? And do they have suicidal ideation? So there are two things that are obviously really important when deciding if somebody has depression or not. And when we say like having a low mood most days, that's what I mean. Like most of us will have days when we don't feel great, when we feel a bit down. That is absolutely normal, and that's just part of the roller coaster that is life. So, but it is.
Caroline? Caroline, we've lost the sound. I think she got disconnected.
She seems to still be on though, Hala.
Okay. Caroline, if you're still on the call, hi.
Yeah, I'm so sorry. My internet's just dropped off. Gosh, I'm not having a good day. And I'm actually at work. I'm not at home. I'm in clinic, so I don't know what's happening. I've turned my camera off to hopefully give me a bit more bandwidth.
Yeah.
I am sorry. Okay, so what happens if we don't treat depression? So the average length of somebody of an episode of untreated depression is about 11 months. And the important thing about depression, like with a lot of actually of psychiatric diagnosis,
We seem to have lost her again.
I know, I think her internet's probably, it's lunchtime, so probably everybody's using the Wi-Fi at hospital right now. Caroline, can you hear us?
yeah, I don't know. I'm so sorry. My network just keeps dropping off.
I
This
was
is
saying
never.
time and everybody's using the Wi-Fi.
It might be. It's never happened in this building before.
Oh dear.
I'm really sorry.
That's okay. We'll carry on.
This-
We'll still have your voice.
This is not ideal when you're trying to present.
Do you have the slides, Nisha?
Yeah, I do, Hala. Sorry, did you say if I have the slides?
Yeah, because it's not being shared anymore, is it?
I am sharing.
Okay. Yep. Okay. Let's just give it one more attempt, Nisha. If not, then we're going to have to reschedule this session.
Yeah, I think so.
Patient, and then
Yeah, with her Wi-Fi going on and off, it's not ideal.
no, I agree. Caroline, are you able to hear us, or is it completely down from your side as well? Yeah, I know it's not going in the flow, Pfizer. Let's just give it a couple of minutes because I know Caroline is super busy with her schedule. So it's not easy to schedule her in for the sessions.
Carla, I'm so sorry. This is awful. So
No,
embarrassing.
it's okay. Do you want for us to reschedule to a different day? Because I'm aware that you have a patient soon.
She seems to have dropped off again, Hala. I think I'll send her an email and
No,
we can
yeah.
probably reschedule her.
That's fine. So if we can stop the recording then, Anisha, we'll reschedule. I do apologize, everybody. Technical problems today.